So as I said, first we will see what is the location and the function. So I am compromising with the grey matter this time because we need to talk about the white matter more. Now first in the line is the dorsal column tract. The dorsal column tract. We have two components of this dorsal column tract, one coming from the lower limb and one from the upper limb, and named accordingly. Now this is called as the fasciculus gracilis, and here we have the fasciculus cuneatus. The medial one is fasciculus gracilis, and this lateral one is fasciculus cuneatus. The fasciculus gracilis carries the sensation from the lower limb and cuneatus from the upper limb. They are carrying the same thing, but gracilis is for the lower limb and lower trunk, and fasciculus cuneatus is for the upper limb. And what exactly goes through the dorsal column tract? What are the sensations that goes through dorsal column tract? The dorsal column tract is responsible for carrying fine touch, pressure to an extent, vibration, conscious proprioception. This is one which I want you to remember all the time, the conscious proprioception. So underline or highlight the conscious proprioception. Stereognosis. Fine touch, vibration, the conscious proprioception, pressure to an extent, and stereognosis. So these are the major things which goes through the dorsal column tract. These are the tracts which are present in the posterior column. See guys, in the neuroanatomy, do not get confused with the name like the column, the fasciculus, the lemniscus, the peduncles, the crus. They all mean the same actually. They are all nothing but the myelinated axons. When you have bundle of myelinated axon, at different level you give them different name. Sometimes you call them tract, sometimes you call them peduncle, you may call them lemniscus, the fasciculus, the funiculus. So there are so many names which are given to them, the crus. So all these are same but nothing, myelinated axons only, the bundle of myelinated axon. Now there is a tract which is to be seen on in the lateral column, or I can say lateral funiculus once again. Now this here is the dorsal spinocerebellar tract, and this one is the ventral spinocerebellar tract. Dorsal and the ventral spinocerebellar tract. The function of the spinocerebellar tract, look at the word cerebellar, they are going into the cerebellum, and when the tract goes inside the cerebellum, it carries proprioception, but what type? Unconscious. We are not aware of that. Unconscious proprioception. That's why I said, remember, conscious proprioception is a function of dorsal column tract, and this is for the unconscious proprioception. Unconscious proprioception. and we also have a tract which is partly present in the lateral funiculus and partly in the anterior funiculus, and that is called as lateral spinothalamic tract and anterior spinothalamic tract. This is lateral spinothalamic tract, and this is ventral or anterior spinothalamic tract. The function of the lateral spinothalamic tract is to carry the pain and temperature. The pain and temperature, except face. I mean, none of this tract is related to face. For the face, we have altogether the different scene over there. We have the trigeminal nerve which is doing everything. So we are talking about the sensation below the face and neck. So it is all about below the face. So pain and temperature below the face is carried by the lateral spinothalamic tract, whereas anterior spinothalamic tract is for touch and pressure, and that this time it will be crude touch. Crude touch and pressure. So this is about the ascending tract, that their location of the ascending tract. See, now we know what are the ascending tracts we have. We know what are their function. We know their location in the white matter of the spinal cord. We know about the grey matter. We already did the grey matter, all those nucleus proprius and nucleus dorsalis and Clark's column. Those are the nuclei where they will relay. Now we are in position to talk about these tracts in detail, that how they reach the thalamus or the cortex or the cerebellum. So let's take these tracts one by one, and we'll start with the easiest one to trace, that is the spinothalamic tract. So we'll first start with the spinothalamic tract. So let us talk about the tracts, and we are starting with the spinothalamic. So let me take some landmarks first, that if let's say this is the midline here, there we have the spinal cord, they have to reach the thalamus, and finally the cortex. The cerebral cortex. This is thalamus. Spinothalamic tract, guys. I told you for any tract, the first order neuron is by the dorsal root ganglia. So the dorsal root ganglia will come from somewhere from here, will enter inside the spinal cord, and will it go into the white matter? It will go directly into the grey matter first. It will go into the grey matter, relay in some nucleus. From that nucleus, that will come into the white matter, and then it will ascend upwards. Now if you remember, what was the nuclei for the spinothalamic tract? What was the nuclei or the grey matter portion for the spinothalamic tract? It was substantia gelatinosa. So if this is DRG, I am writing DRG, that is dorsal root ganglia. Now that dorsal root ganglia will come inside and relay in the grey matter. So let's just, for our convenience, let's say if this is a grey matter here. Somewhere in the grey matter where we have the substantia gelatinosa, and that will end. From the substantia gelatinosa, just a schematic picture here. So let's say this is substantia gelatinosa. From the substantia gelatinosa, the second order neuron will begin, and they will cross over to the opposite side. Few will form the lateral spinothalamic tract, and few anterior spinothalamic tract. The difference is the one which is carrying the pain and temperature. The one which is carrying the pain and temperature will form the lateral spinothalamic, and the one which is carrying the touch and pressure will form the anterior spinothalamic tract. So let's say this is the lateral spinothalamic tract to reach the thalamus, and there's the anterior spinothalamic tract. So make sure you label them in the lower part only here. This is called as the lateral spinothalamic, anterior spinothalamic tract. Lateral and anterior spinothalamic tract. Pain and temperature going into the lateral spinothalamic, and touch and pressure is going, the crude touch and pressure into the anterior spinothalamic tract. Now usually when these tracts they go inside the brainstem, they get condensed, and when they get condensed they form the lemniscus. You'll usually find that there are so many lemniscus present in the brain, like we have the lateral lemniscus, the medial lemniscus, the trigeminal, the spinal lemniscus. So lateral spinothalamic tract will ascend upward and form the lemniscus, which is called as the spinal lemniscus. The spinal lemniscus. So guys, remember, spinal lemniscus is nothing but the continuation of the lateral spinothalamic tract in the brainstem, and anterior spinothalamic tract will join. I'm not saying it is forming it. It will join the medial lemniscus, which we will talk about. It will join the medial lemniscus. There is a reason behind why it joins only the medial lemniscus only. They reach the thalamus, relay in the thalamus, and from the thalamus we have the next order neuron which are starting here, which are going towards the cortex. Anything which comes to the thalamus, see, thalamus is somewhere in the middle. Anything which comes to the thalamus, it will radiate into the cortex in different directions. So we call it corona radiata. Now when the word corona radiata is a vague term, because when we say corona radiata, it means the ascending tract as well as the descending tract, and right now we are only talking about the ascending tract. So we simply call them thalamic radiations, which is definitely a part of corona radiata. So these are called as the thalamic radiations. Radiating to the cortex, thalamic radiations. The important thing to note here is that the DRG, the dorsal root ganglia, is forming the first order neuron. The lemniscus are forming the second order neuron, the spinal lemniscus or whatever, the medial lemniscus, and thalamic radiations are forming the third order neuron. Order neuron, first order neuron is ending in the spinal cord. The tract is crossing over to the opposite side, forming the anterior spinothalamic tract and the lateral spinothalamic tract, forming the lemniscus. Third order neuron is beginning in the thalamus and radiating toward the cortex. So these are the, this tract is made up of three order neuron system, first, second and third order. And remember this thing, that lemniscus are always formed on the contralateral side. You take any lemniscus, all the lemniscus are formed only after the tract is decussated to the opposite side. And that is why one common rule, that any injury to any lemniscus, the effect has to be contralateral. You take spinal lemniscus, see, if there is a spinal lemniscus injury, what will happen? Contralateral loss of pain and temperature. Similarly, lateral lemniscus, which we will talk about, injury to lateral lemniscus, contralateral hearing loss. So any lemniscus injury, the effect will be contralateral only, because lemniscus are formed on the opposite side. So this is the first tract, the spinothalamic tract. Let's talk about the dorsal column tract. And see how the fibers of the dorsal column tract reach the cortex. This time we again consider, let's say there's a midline once again. the spinal cord, let me place the thalamus here, and the cortex. Once again, the first order neuron, the DRG. The dorsal root ganglia is forming the first order neuron. Now look at the catch. The dorsal root ganglia, they will go directly into the fasciculus gracilis and fasciculus cuneatus. These DRG are going directly to the fasciculus gracilis and fasciculus cuneatus. We said we had a nucleus where they will relay, the nucleus proprius. What is happening to that? Yes, the nucleus proprius will relay there. If let's say we have a nucleus proprius here, if you have the nucleus proprius here, can you just zoom this part, this portion. So we have a nucleus proprius there. These dorsal root ganglia, the fibers from the dorsal root ganglia, few of them will give collateral to the nucleus proprius, and from the nucleus proprius then we have the fibers which are coming out and forming the efferent connection. Nucleus proprius is connected by the internuncial neurons to the motor horn, and motor horn is giving off these motor fibers coming out. So basically they have to relay in the nucleus proprius, for the reason the nucleus proprius will act as the center which will participate in the reflexes. You have to maintain the reflexes at the level of spinal cord only. So you cannot have, let's say if there are 100 axons present in the dorsal root ganglia, you cannot have all the 100 going above directly without relaying into the gray matter. Few of them are relaying into the nucleus proprius to maintain the reflex arc at the level of the spinal cord, and rest majority of them, they will directly continue upward. As we know, this is called as the fasciculus gracilis and fasciculus cuneatus. This is fasciculus cuneatus and this is fasciculus gracilis from the lower limb and the upper limb. Now if I am saying the fasciculus gracilis and cuneatus are not relaying, I mean these are still the first order neuron, if they are not relaying in the gray matter, so they must relay somewhere in the brainstem. So they will relay in the brainstem in the medulla oblongata, and those nucleus are called as nucleus gracilis and nucleus proprius. Nucleus gracilis and nucleus cuneatus, I'm sorry. So let's say this is the nucleus gracilis and nucleus gracilis and nucleus cuneatus. And they are present in medulla oblongata, they are present in the medulla. The second order neuron will start from the nucleus gracilis and nucleus cuneatus, and they will immediately cross over to the opposite side. To reach the thalamus. They will immediately cross over to the opposite side to reach the thalamus. Now these fibers are called as internal arcuate fibers. These are the internal arcuate fibers. They are making an arc inside the medulla, and as soon as they reach the opposite side, we said when they reach the opposite side the name changes to lemniscus. Now this is called as the medial lemniscus. The same medial lemniscus which is joined by this tract over here. So this is called as the medial lemniscus, which was joined by the anterior spinothalamic tract. Medial lemniscus, which is joined by the anterior spinothalamic tract. So we have this anterior spinothalamic tract, and there we have the medial lemniscus. Why it is joining the medial lemniscus? What's the reason the anterior spinothalamic tract chose to join the medial lemniscus only? Because there is something common between the two. Medial lemniscus is the dorsal column tract, and if you remember, dorsal column tract carries the touch and pressure, and medial lemniscus is joined by the anterior spinothalamic tract. Anterior spinothalamic tract is also carrying the touch and pressure. Yes, one is crude touch and one is fine touch, but in both we have the touch and pressure, so they travel in the same lemniscus, and that is medial lemniscus over there. And once again the same story from the thalamus. The third order neurons are the one which are projecting into the cortex, and these are called as the thalamic radiations, just like on this side. So I can say on this side the first order neuron is by the dorsal root ganglia. The second order and fasciculus, gracilis and cuneatus are also the first order neuron only. Second order neuron is by the internal arcuate fibers, or you can say the medial lemniscus, and third order neuron is again the thalamic radiations. The important thing in all the tract is the level of decussation, so that you can decide that what will be the effect of the injury. Guys, if I say the injury is to the lateral spinothalamic tract at the level of spinal cord, or I say injury to the spinal lemniscus in the brainstem, in both the cases the effect will be contralateral, because the tract is decussating at the level of spinal cord itself. So we have a contralateral loss of pain and temperature here also and here also. But the story is different here. If you have an injury of the fasciculus, gracilis and cuneatus, the effect will be ipsilateral. There will be ipsilateral loss of conscious proprioception. Let me take the important one. But if the injury is to the medial lemniscus, then the effect will be contralateral. So you must know at what level they are decussating. That is decussating at the level of spinal cord. This one is decussating at the level of medulla oblongata. So injury above the medulla oblongata, the effect is contralateral because we have an injury to lemniscus. Effect injury below the medulla oblongata or in the spinal cord, the effect is ipsilateral in case of dorsal column tract. So these are the two tracts, the two major tracts, spinothalamic and dorsal column tract. So there is one more left which we will talk about, that is the spinocerebellar, which is completely different because both these tracts are reaching the thalamus, and everything which goes to the thalamus now it is projected toward the cortex. I mean, nothing goes to the cortex directly, it has to go to the thalamus and then into the cortex, except olfactory. Olfactory is the only tract which is going directly into the cortex. And please note one more thing here, that out of all the sensation which are going through the spinothalamic tract, the pain, temperature, touch, pressure, highest center for the pain is thalamus only. Pain will not go into the cortex. There is no area in the cortex which represents the pain. So please note, thalamus is the highest center for pain. Thalamus is the highest center for pain. Now let's talk about the third and the final ascending tract that we have, and that is the spinocerebellar tract. So we'll talk about the spinocerebellar tract. Spinocerebellar tract. So let's see how the spinocerebellar tract will reach their destination. This time the destination is cerebellum. The name itself is saying spinocerebellar. So let's say guys, these are the three cerebellar peduncles. if this is a cerebellum here, so these are the three cerebellar peduncles. Cerebellar peduncles. Crus cerebri was the another name for the cerebral peduncle. Now these are cerebellar peduncles. When you say the word cerebellar peduncles, that means they are connecting the cerebellum to the brainstem, to the midbrain, to the pons, to the medulla oblongata. So guys, cerebellar peduncles, these are superior cerebellar, middle cerebellar and inferior cerebellar peduncles. I'm just writing it for one, that is superior cerebellar peduncle. So these are the cerebellar peduncles which are giving passage to the tracts which will go inside the cerebellum. Now for that means, let's say if this is the, let's divide the brainstem in three parts here. So that is the midbrain, the pons, the medulla. So let's say these are the lines which are dividing the brainstem. We have the three parts of the brainstem, the midbrain, the pons and medulla oblongata, connected to the cerebellum by these three cerebellar peduncle. These are the gateway, or these are the passage peduncles. Once again the word is peduncle, the white matter. We have a tuft of white matter bundle here which is a communication between all these different parts of the brainstem. Now let's say if this is a spinal cord here somewhere, so there is a spinal cord, DRG, once again the first order neuron. And what was the relay station for the spinocerebellar tract? This is DRG, the first order neuron. The second order neuron will begin in the grey matter, and that was nucleus dorsalis, if you remember. Nucleus dorsalis or Clark's column. So second order neuron will start from the nucleus dorsalis or Clark's column with two fate. One might go to the same side, the one which are going to the same side ascend upward to reach the inferior cerebellar peduncle and enter the cerebellum through the inferior cerebellar peduncle. I mean, they go to the medulla oblongata and enter through the inferior cerebellar peduncle. Another fate is if they cross over to the opposite side, ascend upward all the way to the midbrain, and from the midbrain they again come back to the same side and enter through the superior cerebellar peduncle. Now this one here is called as the dorsal spinocerebellar tract. Dorsal spinocerebellar tract. We had two spinocerebellar tract, dorsal and ventral. That's the difference. The one which is running on the same side and enters through the inferior cerebellar peduncle, that's the important information, is called as dorsal spinocerebellar tract. And the one which crosses over to the opposite side and goes all the way to the midbrain and then go back is called as the ventral spinocerebellar. Ventral spinocerebellar tract. Dorsal spinocerebellar tract and ventral spinocerebellar tract. Now maybe to your surprise, the dorsal and ventral spinocerebellar tract, they are carrying the unconscious proprioception from the body, except upper limb. Upper limb will not give off its unconscious proprioception through the dorsal or through the ventral. There is a different arrangement for the upper limb unconscious proprioception. So let us see what is that arrangement here. Unconscious proprioception from the upper limb. Now look at this first. Unconscious proprioception from the upper limb will come through the dorsal root ganglia and they will go into the fasciculus cuneatus to reach the medulla oblongata. So this is fasciculus cuneatus. We already said fasciculus cuneatus and gracilis are carrying the conscious proprioception, and now I am saying fasciculus cuneatus is also carrying the unconscious proprioception of the upper limb, and because it is unconscious proprioception, so it will not relay in the nucleus cuneatus. Nucleus cuneatus was for which proprioception? It was for the conscious. There is another nucleus present in the medulla oblongata which is called as ACN. This is called as ACN. ACN is accessory cuneate nucleus. It is present just behind, just very close to the nucleus cuneatus. We call it accessory cuneate nucleus. And this accessory cuneate nucleus will give the second order neuron which will go again through the inferior cerebellar peduncle. This tract, guys, I am making a star here, this tract is called as cuneo-cerebellar tract or cuneo-cerebellar fibers. Passing through the inferior cerebellar peduncle, these are called as the cuneo-cerebellar tract. This is how the unconscious proprioception of the upper limb reaches the cerebellum. Unconscious proprioception of the upper limb reaches the cerebellum. So unconscious proprioception, rest is going through the dorsal and ventral spinocerebellar tract, but for the upper limb they go through the dorsal root ganglia into the fasciculus cuneatus, relays into the accessory cuneate nucleus, takes a second order neuron from the medulla oblongata to the cerebellum through inferior cerebellar peduncle called as cuneo-cerebellar tract.